Guys, welcome to our channel. Today we are going to discuss about the medicine rapid revision lecture. So in this, I have divided into the two parts. The part one will be consisting of the cardiovascular system, respiratory system, rheumatology, and renal system. And part two will consist the neurology, GIT, and hepatology, and also endocrine and hematology. These topics will be covered. So please do watch these two videos because Mission 200 plus we are aiming medicine is going to be the one of the game changer in this program. Okay, so let's start today's session. So the first topic will be cardiovascular system. Before we move on to the cardiovascular system, I want you guys to know about the cardiac cycle again. Revise this because the most of the concepts will be based on our cardiovascular cycle only. So let's start. So what happening here? Here you can see the first phase will be the arterial systole, then ventricular systole and diastole, right? This is the cardiac cycle that we have learned. But this should be interlinked with where the valves is opening, where the valves is closing, how the pumping is happening. So that's we have to see. So first, always remember when I start the cardiac cycle, I would prefer the isovolumetric contraction. Okay. So what happening during the isovolumetric contraction? So let's see. Isovolumetric contraction. So during this phase, what happens? All the valves in the four sides of the all valves will be closed. Okay. This is the first phase, isovolumetric contraction. So this will be triggering to the when the pressure, all the valves is closed, the pressure will be increased, right? The pressure when it will reach the 120 mmHg, it will cause the rapid ejection. Okay, rapid ejection. So these rapid ejection will be happening from where? Which valves are going to open here? So this one you have to remember, guys, where the aortic and the pulmonic valves is going to open. So this will cause the aortic ejection, right? Same pressure when we check the BP also we get because this is due to rapid ejection. Okay, next, what are the valves that is closed here? The mitral and tricuspid valves are going to closed. So these two valves, when they close, they make the sound. That sound is known as a lub. S1 sound is produced here. So this is most of the 80% of the blood is ejected from the rapid ejection only. Next, it will be continued by the slow ejection. Okay, slow ejection which will be carried. Next, after this we are going to moving on to the isovolumetric relaxation. Okay, isovolumetric relaxation. During the isovolumetric relaxation, again all the valves are going to be closed. All the valves are closed. Okay, slightly there will be rapid filling. Rapid filling means all the ventricles should be filled, right? During this rapid filling, so from the IVC, the right atrium will be going to fill, and from the right atrium and the left atrium, both the ventricles going to fill it up. So this phase is known as a rapid filling. Again here 80% of the blood will be filled, and that's why this is also known as a stasis of the blood. This phase is known as a stasis of the blood. So what are the valves that are opening here? So the mitral and the tricuspid valves are going to open because these are the AV valves, right? When these AV valves are open, so easily this can fill into the ventricles. What are the valves that are closed here? Aortic and the pulmonic valves. So when these valves are closed, it will cause the dub sound. This dub sound is known as an S2 sound. So this is the main phases that you have to remember. Next, slow filling will be continued. Slow filling around 20% will be continued. So again, the cycle will be vicious. So what is the systolic phase here? So this is our systolic phase. This is our systolic phase. And here, this is our diastolic phase. Okay. This is what main importance of the cardiac cycle that you have to remember. Next, coming to the, this is the pressure and this is the volume. So these pressure volume graph that you have to identify. Let's name the different This is the point A, point B, point C, and point D. Okay. So what happening between the point A to B, point B to C, point C to D? Here we are going to see here. So first thing, what happening in the volume? So when the volume is going to increase, the graph is also going to move that direction only. So once it reach there, at some point, there will be increase in the pressure. So this will be hike in the pressure. So after that, when the pressure is down, again, it will be coming back to the volume where it is a normal value, right? That is what the pressure volume graph should be interpreted. So first, from point A to B, there is a diastolic filling. So from the volume of the 40, it is going to increase up to 120 value, right? So once this value is reached at point, this mitral valve is going to closed, right? Where our S1 sound is produced. This going to increase the pressure. Once it reaches the more than 100 pressure, it is going to open the aortic valve, right? At least 120 mmHg of the pressure is increased, it will open the aortic valve at the point of C. After this, systemic ejection. So from the aortic wall to the system, it is going to ejected. Now here, at this point, aortic valve is going to closed. So the S2 sound is produced here. So from the S2 sound, it is going to come back to its normal value by the relaxation to the 40 ml of the value, right? So see here. So what is happening in the point A to B? So there is a diastolic filling. Okay, there is a diastolic filling. And next, coming to the B to C, at point B, what happened here? The point B is produced S1 sound. Point B to C, it is isovolumetric contraction. Point C to D, systemic ejection, right? Systolic ejection. And point D, only if the point D is mentioned, then it is S2 sound. Again, D to A, it is going to be the isovolumetric relaxation, right? This is the pressure volume graph that you have to remember and very important for our examinations. Next, moving on to the cardiomyopathies. So three cardiomyopathies that I am going to discuss here. So the first one is the dilated cardiomyopathy, hypertrophic, and the restrictive. Which is the most common? The dilated will be the most common cardiomyopathies. So let's come to the dilated cardiomyopathy. So this is the most common among all the cardiac myopathies. So what is the most common cause then? So the most common cause is the alcohol. Okay, alcohol patient. Then it is going to be the genetic conditions. Genetic conditions, especially the titin. This titin deficiency is going to lead the genetic dilated cardiomyopathy. But there are other significant causes also. For example, when the patient is on the peripartum, okay, peripartum cardiomyopathy, and also smoking, alcohol, as we mentioned, and patients, those who are taking the cocaine kind of drugs and viral infections can cause, and also when they have the selenium deficiency, okay, selenium deficiency, sarcoidosis, and hemochromatosis. So all these are going to be the causes for the patients of dilated cardiomyopathy. How the dilated cardiomyopathy should be understood. So when the dilated cardiomyopathy, you can see it is completely dilated in all the directions equally. So the dilatation will be symmetric. And how about the movement? The movement is going to decrease. So it is hypokinetic, symmetric and hypokinetic. How much it is going to dilated? More than 6 mm, equal or the more than 6 mm, it is going to be dilated in all the sides of the ventricles. So what is the treatment of the choice for this patient? So this patient is highly developed systolic heart failure. Okay, systolic heart failure. So the treatment should be treat the underlying cause. Treat underlying cause. So if the patient is taking the alcohol, try to quit the alcohol. Cocaine, try to decrease. Peripartum, treat the partum period. And sarcoidosis, again. So most of the underlying causes should be treated. So treat the underlying cause is the treatment for this patient. Right? Next, moving on to the hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, this is the most common genetic disorder in the cardiac. genetic disorder in the cardiac system, whole cardiac system. This is the most common genetic system. So what are the causes? Again, this is the main cause of the genetic. So bifiray, okay, bifiray myofibrils will be seen when you're going to do the histopathology. On the histopathology, there will be myofibrils, disturbed structure you are going to see. Then what about the symptoms? So the symptoms of these patients will be same as a angina, and also the patient is going to have the chest pain, same as the angina, but angina will be associated with the work, and also patient will be having the dyspnea kind of symptoms. And some of the patients, at least 50% of the patients will be asymptomatic only. And when we are going to check this patient heart, here you can see this completely going to be hypertrophic. So this is called as a banana shaped heart also. So these heart, when it is produced more, it is going to cause the obstruction. What happens? It has to pump here, right? It has to pump to the systemic circulation. But when it is completely going to block, it will block this valve. So once it is going to block, you cannot get the blood from the aortic valve, right? So that will cause the significantly sudden cardiac death. So the patient will be high chance of the hypertrophic obstructive cardiomyopathy, which will cause sudden cause of death. Okay. And another symptoms, you are going to see the pulses, bifurence, and also jerky pulse will be seen in this patient. And the heart on the echocardiography, it is going to be asymmetric and hyperkinetic. So more and more movement will be seen. Heart failure will be diastolic heart failure. So what is the treatment of this patient? So the treatment will be heart transplantation, because the disease in the, where guys, the disease is going to be in the patient genetics. You cannot change the genetics. So heart transplantation can be done. And other treatment what we can do is the completely myomectomy. We cannot do the myomectomy from the heart, but what we can do with the help of the alcohol, we can ablate the movement, ablation of the that particular myo segment. Okay, so how that can be done? So here you can see this is the completely hyperkinetic, right? If it is move on, keep on movementing, what we can do, we can ablate this with the help of the alcohol, so that the movement will be decreased, the obstruction chances will be decreased in this patient. And the supportive treatment will be beta blockers. You can give the beta blockers to decrease the heart rate. Next, moving on to the next moving on to the restrictive cardiomyopathy. This is very rarely seen, but mostly associated with the conditions like, the most common will be amyloidosis. Okay, amyloidosis patient, this is the most common cause. And other patients like radiation, post-radiation, this can be seen, and also other genetic syndromes will be associated. And also LSDs like lysosomal storage disorders and glycogen storage disorders, or patients those who are suffering from the cholesterol disorders. Okay, very genetic rare conditions will be associated with the condition of the restrictive cardiomyopathy. And how these will be presented, patient will be mostly akinetic movement and asymmetric movement. So when these both are associated, no movement or the no symmetry of their restriction, what happens? The patient will be having the both symptoms like heart failure symptoms from the systolic, and at the same time they also presented with the diastolic symptoms. So these both symptoms will be seen in the patients of the restrictive cardiomyopathy. So again, the treatment will be for this patient also, treat underlying cause. Treat underlying cause. So already it is asymmetric, you cannot give the beta blockers. Okay, most of the cardiomyopathies, if they are untreated, the only choice that we are going to have is the heart transplantation only. Now here you can see this is the picture. So this is Takotsubo cardiomyopathy, which is also known as a stress cardiomyopathy or the broken heart cardiomyopathy. This is also known as a broken heart cardiomyopathy. So Takotsubo is a Japanese word. What happens in these patients? Usually when there is a sudden news like patient, someone relatives is died, someone close person is died, what happens? There is a very high range of the stress will be triggered. So which will lead to the release of the sympathetic system. So the sympathetic system will take the help from the catecholamines. Okay, will take the help from the catecholamines. What these catecholamines will do? They are going to be surge. So the catecholamine surge will be happening. So which will lead to the cardiac muscle is going to have the kinetic movement. So hyperkinetic movement. So these hyperkinetic movement will completely going to use the ATP. So once this ATP is decreased, when the ATP is going to depleted, this will cause the biventricular contraction will be stopped. Biventricular akinism. Okay. So akinism, when the both the ventricles are decreased, so this is how the patient will be going to have. Okay, this is known as a apical ballooning. Okay, apical ballooning. So this is the symptom that is going to presented in the patient. So what about the patient symptoms? The patient symptoms will be same as a MI. The chest pain will be seen in this patient. When you do the ECG is also going to show the ST changes. Okay. And what about the TROPS? TROPS is also positive due to suddenly the biventricular mechanism because all the ATP is already consumed. Next, on the echocardiography, on the echo is only going to help you because this is reliable. On that only you are going to see this apical ballooning. What is the treatment of the choice for this patient? So dilatation is the choice for this patient. Balloon and dilatation can be done as a procedure for this patient. Next, so this is the Takotsubo can sometimes mimic the MI, but it is not MI condition. All right. Next, we are going to move on to the next myocardial infarction only. So the myocardial infarction, which is also known as a coronary artery disease. Let's see. So the myocardial infarction or the coronary artery disease, the most common cause will be patients those who are suffering from the atherosclerosis. Okay, atherosclerosis. And the second most common is smoking. Premature deaths with the MI, that is due to smoking. If the patient is more than 50, then it is most likely atherosclerosis, right? Next, most common artery. So the most common artery will be left anterior descending artery, which is also known as your widow artery. Okay, because the mostly anterior will be dominant with the right coronary artery. It is only going to stay in the anterior region. That is why it is known as a widow artery, left anterior descending artery. Let's see the difference between the what is the angina. First, stable angina, and you also have the unstable angina. What is between this unstable angina and stable angina? Before that, we see how this patient going to present it. So the presentation of this patient will be chest pain, and how this chest pain is going to present it. Basically, the patient will be telling it is throbbing, pressure, and they are going to clenched fist at the chest region, and explaining it is pain. So this is known as a Levine sign. This is known as a Levine sign, and the pain will be radiating. So the pain will be radiating towards the shoulder and also jaw, infrascapular region, and also infrascapular region. This is due to thoracic. This is due to thoracic sympathetic system. Thoracic sympathetic nervous system is going to act here. The peripheral system is activating. And also the patient will be having the diarrhea and vomitings, which is unexplained by the intake of the food, and also sweating. All these symptoms will be seen in the classically in the patients with the MI. So stable angina, unstable angina before the myocardial infarction is started. So how the patient with the stable angina, the pain is presented only upon work, and this pain will be subsided. This pain will be subsided with rest. So this is the first point that you have to remember about the stable angina, and no treatment is needed. No treatment is needed for this patient. Only the prevention will be from the secondary prevention that we can go for the stable angina. Next, unstable angina, the pain will be presented upon work and not subsided by rest. So if it is not subsided by the rest, then the patient progression is already seen. So what we can do, so we have to give this patient nitrates. Sublingual nitrate should be given for this patient. Okay. And if you forget or left untreated this patient, what happens? It can progress to the NSTEMI. What does mean by the NSTEMI versus the STEMI? What is the difference between the NSTEMI and the STEMI? So the STEMI means ST elevated myocardial infarction. So this is non-ST elevated. ST elevated is always going to be the severe condition. Okay. So again, these patients will be, pain will be presented, radiation will be presented, diarrhea, sweating can be also seen in this patient. So we have to rely on the ECG here. So the symptoms are going to be the common only. But what is the ECG changes? ECG changes will be no ST elevation, non-ST elevation. So other than that, you are going to see the T inversions and ST depressions. And coming to the patients with the STEMI, you are going to see the patients with the ST elevation. Okay, this will be the classical condition. ST elevation is already seen. Next, TROPS, the enzymes that you have to reliable. So the TROPS will be negative. Here it is TROPS is going to be positive. So this is the major change between the NSTEMI and the STEMI. Next, what is the treatment of the choice for this patient? So when the STEMI patients is presented, what is the treatment of the choice that you are going to give? Here the treatment will be morphine, oxygen, and also patient should be given the nitrates to treat the vasodilation, and at the same time aspirin plus clopidogrel, the dual antibiotic should be given for this patient. Okay, this is the basic treatment, but you have to treat as soon as possible. Either you are going to open the open graft or you are going to do the PCI intervention. But how the PCI intervention should be done in this patient? So the door to balloon time for the PCI intervention will be less than 90 minutes. Okay, so this is the basic system that you have to move. Whenever you see the patient with the STEMI, immediately the PCI intervention should be done within the 90 minutes. If not, if it is not a non-PCI center, if it is not a non-PCI center, then less than 120 minutes, you have to reach the PCI center and then you have to go for the PCI. And if it is not treated by the PCI, then you have to go for the CAPG, the coronary artery bigraft, that you have to do. This is for the STEMI patient. What about the NSTEMI patient? The NSTEMI patients also, the treatment will be same. What is the treatment, guys? Give the morphine, if needed, oxygen, and then again nitrates, or you can go for the patients with the antiplatelets is compulsory. Antiplatelets should be given, but depends on the severity. If the patient is mild or moderate, then in the less than 24 hours, we can go for the thrombolysis. But if the patient is severe, then less than again 120 minutes, you have to reach the PCI intervention for this patient. Less than 120 minutes, you have to go for the PCI intervention as soon as possible. So this is the myocardial infarction and their treatment protocol. Next, moving on to the hypertension. So hypertension, basically the classification is as per the 2024 guidelines only, we are still following. The patient with the more than or the 120 to 129 and less than 80, that is known as a elevated blood pressure already. What is the stage 1? The 130 to 139 or 80 to 89. This is considered as a hypertension stage 1. Then stage 2, high blood pressure, hypertension stage 2, more than 140 or more than 90. Again, it is R, guys. Next, hypertensive crisis, more than 180 and or higher than the 120. This is considered as a hypertensive crisis. Next, what is the drug of the choice when the patient is presented with the hypertension? So before that, we used to do beta blockers, but now the drug can be given as a first line is the ACE inhibitors. Okay, the captopril or the lisinopril that can be given, or we can also go for the herbs such as losartan. Those drugs can be also given for this patient. So the drug of the choice for the hypertension, first stage, that you have to go for the ACE inhibitors or the herb inhibitors. Next, what about the patients with the resistant hypertension? Okay, resistant hypertension. Why this resistant hypertension is seen? More than or equal to 2 dual therapy, you already this patient with these drugs plus or minus diuretics, you add it, still the hypertension is not controlling. So this is the classical definition for the resistant hypertension. What could be the most common cause? The most common cause will be incompliance. The patient is itself incompliant to take the drugs. What about the other causes? Endocrinopathies. What are the endocrinopathies that is associated with the highest condition of the resistant hypertension? Either it could be thyroid conditions or it could be cons aldosterone symptoms. And even those who are suffering from the obesity patient and pheochromocytoma, these are the some of the causes that you have to remember for this resistant hypertension. And also renal artery stenosis, this can be also seen as a resistant hypertension. Then what is the treatment for this patient? The treatment for this patient will be spironolactone. Spironolactone is the drug of the choice for the resistant hypertension. Then you also have the orthostatic hypertension. Orthostatic hypotension, sorry, hypotension. The most common cause for the orthostatic hypertension is the autonomic system, right? The autonomic system disturbances. This is the most common cause. When the autonomic system is disturbances, what we can go for the alpha drugs. So though the drug of the choice will be midodrine. Okay, midodrine can be given for this patient because it will cause the again vasodilation, and when it is an alpha antagonist, it will cause the vasodilation. The patient will be having the hypotension will be decreased from this patient. Next, we also have the urgency versus the crisis. Okay, we also have the hypertension urgency and also hypertension emergency. So what does mean by the hypertension urgency? Again, more than 180 or more than 120. Okay, same as here, more than 180 or more than 120. So what happened? Urgency means no organ damage, though no multi-organ damage. But here, multi-organ damage will be presented here. So the drug of the choice here is the oral clonidine can be given. But here, the drug of the choice for this patient is the IV drug only. The nicardipine can be given. Okay, nicardipine, or also you can go for the labetalol. At the same time, you have to treat the patient system also. Other system shall be also treat the immediately. So this is the hypertensive urgency and the hypertensive emergency. Now moving on to the heart failure. So heart failure, here you can see the most of the heart failures will be either compensated or the decompensated. So the what is mean by the compensated? That means the ejection fraction is going to be preserved. So this is usually the most common. 50% of the heart failures will be mostly compensated, and these are known as a diastolic heart failures. Okay, and remaining less than 30% is going to be decompensated, and these decompensated are going to be systolic heart failures. And here you can see 50 plus 30, 70, remaining 20% will be both. Either it is going to combine with the systolic diastolic, or going to be these diastolic is only going to be the chronic heart failures. Okay, this is what you have to understand from the both compensated and the decompensated. So the preserved ejection fraction for the diastolic and reduced ejection fraction for the systolic heart failures. What is the most common cause then? The most common cause for the patients, those who are suffering from the heart failure is known for the hypertension. This is the most common cause. And then ischemic heart disease. This is also second most common. And what about the symptoms of the heart failure patient? So it can be divided as a right heart failure, mostly systolic heart failures. Okay. And next, left heart failure, diastolic heart failures. So how these patients are going to present it in our OP. So let's see the differences, guys. So the right heart failure, the mostly right atrium itself, there is a problem. So the JVP rise will be seen. So if the right atrium cannot pump, what happens? There will be again the hepatojugular reflex will be increased. Hepatojugular reflex will be also raised, and there will be edema, right? Systemic circulation, the IVC have to empty, but it is cannot empty, so it will cause the edema, like whole body edema will be seen. But left heart failure is most commonly it is associated with the pulmonary edema, because left atrium is going to pump back to your lungs, so pulmonary edema is seen. So if this pulmonary edema on the chest x-ray, you are going to see the Kerley B lines on the chest x-ray you are going to see. Other than this, the symptoms will be the patient will be having the cough, chronic cough, and the dyspnea can be seen. And if it is progressive, you are also going to see the orthopnea, right? Positional shortness of breath, or paroxysmal nocturnal dyspnea, specific for the heart failure with the left heart failure. Specifically during the night times, the episodes of the dyspnea will be seen in this patient. So this is the symptoms of the right heart failure and the left heart failure. What about the treatment? In the acute phase of the treatment, because in this phases, what we can do, beta blockers to decrease the heart rate, and also to control the hypertension, ACE inhibitors can be given, and also diuretics can be given. In this stage only, if the patient, we can treat with the ionotropes also. What about the chronic treatment? Chronic treatment also, we are also going to include the beta blockers, calcium channel blockers, digitalis, and also ACE inhibitors, diuretics. Along all with this drug also, the main drug that we have to include is the nephrolysin inhibitor. What is this nephrolysin inhibitor? Sacubitril. Okay, this is known as a sacubitril drug. This drug is going to be the game changer for the chronic heart failure. What about the drugs that is going to decrease the mortality rate of the heart failure? The mortality of the heart failure will be decreased by the first ACE inhibitors and ERB drugs, and also beta blockers, diuretics. Diuretics can also going to decrease. SGLT2 drugs is also going to decrease. Ionotropes, calcium channel blockers, all these main drugs is going to decrease. Sacubitril can also decrease the mortality of the heart failure will be decreased. So this is the overview of the heart failure. But here you have to understand why the heart failure is triggered again and again. Okay, so let's see the mechanism of the heart failure. So heart failure, the most common cause will be left ventricular hypertrophy, right? Left ventricular hypertrophy is the most common cause. Due to hypertension, the patient will be having the hypertension, which will lead to the left ventricular hypertrophy, right? This is the most common cause. What happens when there is a left ventricular hypertrophy? It will cause the fluid overload because it cannot pump properly. So these fluid overload, which will lead to the decreased blood pressure and also decreased cardiac output. So once this cardiac output is decreased, it will trigger the kidney, right? This kidney will release the renin from the system. So this renin is going to release the aldosterone. What is the main mechanism of the aldosterone? It is going to increase the sodium absorption along with the more fluid. So this is going to cause the blood pressure increase with the help of the vasoconstriction. So the blood pressure will be increased in this patient. Along with that, fluid is also going to increase. Already, but our patient is already on the fluid overload. So it will further worsening. The condition is already further worsening. Next, again, the kidney, another role of the kidney, ADH, right? ADH will be activated. Again, ADH will be activating on the endothelins of our vessels, right? We have the V1 and V2. So either it will act on the kidney and at the same time it is going to act on the blood vessels, capillaries. Again, there will be more vasoconstriction, more increase of the BP will be seen in this patient. So overall, our triggering factors of the ADH and the renin, which will further worsen the condition, right? More BP and more fluid overload will be seen in this patient. So what happens when this happening? There will be decompensation from the atria. So atria with all the increased pressure, atria will trigger its cells. What are those cells? ANP peptides and BNP peptides. From the brain and from the atria, they are going to be released these drugs. What are these? One, natriuretic peptides. Natriuretic peptides. These natriuretic peptides will release into the circulation and going to decrease the sodium. Along with that, they are also going to decrease the water, right? Natriuretic peptide. So the sodium and water is going to excreted from the body. Okay, excreted from the body. So this is the drug that we are going to using. This drug is known as a nephrolysin inhibitor. Okay, nephrolysin inhibitor or the sacubitril drug that we are going to encourage here, right? This is the main mechanism behind the heart failure. Next, moving on to the heart valves, valvular heart diseases. Before you have to know about the valvular heart disease, again revise it. Isovolumetric contraction, rapid ejection, slow ejection, and isovolumetric relaxation, rapid filling, and slow filling. Right? So this is the phase of the systolic. This is the phase of the systolic, and this is the phase of the diastolic. Diastolic phase. So mainly in the systolic phase, what happening? There will be opening of the mitral and there will be opening of the aortic and the pulmonic. Aortic and pulmonic valve will be open and close the mitral and the tricuspid valves. Right? Next, in the diastolic, what happening? So there will be open of the mitral and tricuspid valve and close the aortic and the pulmonic valve. Right? So if you understand keenly why I have revised again here means, so during the opening of the aortic and the pulmonic, what are the murmurs that is going to associated here? So when these aortic and the pulmonic valves are open very slightly narrowly, so there will be aortic stenosis and the pulmonic stenosis. Murmurs will be occurred at the phase of systolic, and mitral regurgitation because it is closed again is regurgitating back. So mitral regurgitation and tricuspid regurgitation murmurs will be seen in the systolic phases. So same as here. So mitral stenosis and tricuspid stenosis murmurs in the diastolic phase, and aortic regurgitation and pulmonic regurgitation murmurs will be seen in the diastolic phase, because what is opening, that is going to be the stenosis, what is closing is going to be cause the regurgitation. This is the difference. When you see, you don't have to confuse the from the question these murmurs, you can easily answer also. Okay, so that's the thing that you have to remember. Before that, I want to before we start into the all the valvular heart diseases, I'm going to discuss the mitral valve prolapse, also known as your Barlow syndrome. So what is the most common cause for this mitral valve prolapse? The most common is the myxomatous degeneration. Myxomatous valve degeneration is the most common cause of this patient, and other will be Marfan syndrome. And what is the symptoms of this patient? The first one, on the examination, you are going to listen the mid-systolic click, and late systolic murmur. Late systolic murmur. This is seen in the patients of the mitral valve prolapse. Atypical chest pain will be seen, and recurrent syncope attacks. And treatment will be valve replacement. Valve replacement is the treatment for this patient. So this is the mitral valve prolapse. Next, moving on to the other important types that we are going to discuss here today. So the first one will be aortic stenosis. The first will be aortic stenosis. Let's see aortic stenosis. The most common cause will be age. Okay, age degeneration or associated with the atherosclerosis. Atherosclerosis. And other cause will be rheumatic heart disease. Most commonly, other causes will be rheumatic heart diseases or the age only. And next, aortic stenosis will be associated with the pneumonic. ASD, atrial septal defect, right? But you have to remember this as this way: angina, syncope, and dyspnea. These are the main symptoms that is presented. So the patient is having the dyspnea, so then you should not give the diuretics for this patient. Diuretics will be contraindicated. This is the commonly that is seen with the aortic stenosis. What is the murmur then? The murmur will be early systolic murmur. Early systolic murmur will be seen in this patient. Next, coming to the aortic regurgitation. Aortic regurgitation. In the aortic regurgitation, the patient most common cause will be hypertension is the most common cause, and they will be the specific signs that is presented in this aortic regurgitation. The first and most common will be water hammer sign. What is the water hammer sign, guys? There will be collapsing pulse. When you check the patient pulse at the radial region, the pulse will be collapsing. So that is known as a water hammer sign. And also Corrigan pulse, or sorry, Corrigan sign. So this is known as a carotid pulse. Carotid pulse is visible. When you are looking at the carotid region, the pulse will be visible. And also lighthouse sign. Lighthouse sign. This lighthouse sign will be pallor on the forehead. The patient will be having the pallor on the forehead region. That is seen in the lighthouse sign. What about the murmur? The murmur will be Austin, Flint, or early diastolic murmur. This is seen in the aortic regurgitation patients. All right. Next, mitral stenosis, the most important one. Mitral stenosis. Mitral stenosis, the most common cause, we all know that is rheumatic heart disease, right? This is the most common cause. What about the symptoms? The symptoms will be syncope and also fatigue. Recurrent fatigue will be seen in this patient. And hoarse voice will be seen. Why this hoarse voice is seen in the patients of the mitral stenosis is because when there is a mitral stenosis, obviously there will be left ventricular hypertrophy. So left ventricular hypertrophy or the left atrium is dilated. This will compress the left recurrent nerve. Recurrent laryngeal nerve is compressed. So left recurrent laryngeal nerve is, when it is compressed, it will cause the hoarse voice. So this syndrome is known as a Ortner syndrome. Okay, this syndrome is known as a Ortner syndrome. What about the mitral stenosis? This patient, again, here also the diuretic should be not given. Diuretics is contraindicated because it can trigger the pulmonary edema in this patient. Okay. Next, pulmonary edema can be treated with the furosemide, that is also diuretic, but this can lead to the heart failure. So valvular heart disease with the heart failure should not be given as a diuretic in the first phase. And what about the murmur that we are going to see? The murmur in this patient will be mid-diastolic murmur. Mid-diastolic murmur is seen in this patient. Okay, next, mitral regurgitation. Mitral regurgitation. Mitral regurgitation, the most common cause will be rheumatic heart disease. So mitral regurgitation is actually mitral stenosis. When it is progressed, it will cause the mitral regurgitation. So it is a combination. Every patient will be having the mitral stenosis and the mitral regurgitation. So this will lead to the patient with the severe condition, right? So there will be a high chance that the patient will be having the heart failure risk. And the symptoms will be dyspnea and palpitations is commonly seen in this patients. All right, this is the one thing that you have to remember. And what about the murmur? The murmur, again, see, mitral stenosis and the mitral regurgitation, both are coming. So pansystolic murmur is seen here. Pansystolic murmur is seen. This is also known as a associated with the pseudo-collapsing pulse. Pseudo-collapsing pulse along with the murmur when you check. Okay, this is the mitral regurgitation. Next, tricuspid stenosis. Again, rheumatic heart disease is the most common cause. So on the JVP, you are going to see the Canon A waves, and the murmur is mid-diastolic murmur. Only important points for the other types. Okay. Next, tricuspid regurgitation. Here, in this also, the most common cause will be rheumatic heart disease. And rheumatic heart disease or the patients when this rheumatic heart disease, it can trigger the right heart failure because tricuspid valve is in the right atrium. So tricuspid right heart failure will be seen in this patient. On the JVP, you are going to see the absent X descent. And also there is a specific sign is seen here, Lancisi sign. Lancisi sign means when suddenly when you are looking at the JVP will be raised. Lancisi sign will be JVP is raised, and at the same time on the JVP the C and V wave will be together. Okay, the C and V wave will be together and merged on the JVP. That is known as a Lancisi sign. The murmur is holosystolic murmur. Holosystolic murmur. Next, pulmonary stenosis. It is commonly seen in the genetic condition like Noonan syndrome or acquired carcinoid syndrome. And the murmur will be systolic murmur. Next, pulmonary regurgitation. This patient, again, hypertension and rheumatic heart disease is the most common cause. And the murmur that is known as a Graham-Steele murmur or diastolic murmur that you are going to see in the pulmonary regurgitation. Next, we also have the one more, the condition that you have to discuss here is the cardiac tamponade. Okay. Cardiac tamponade. What happened in the cardiac tamponade? Usually, the patient is the most commonly affected with the trauma. So when there is a trauma, it can lead to tear here. So or tear, the patient, what happens? There will be release of the fluid into the pericardial tissue. This is the pericardium, is going to cover the heart. So, but inside this, there will be increase the blood. Okay, this blood will lead to the pressure, right? It will pressure, and at the same time, it will compress the valves. Okay, it is going to compress the whole heart on all sides, right? Equally on the all sides, the heart is going to be compressed here. So once this is compressed, what happens? It can compromise the cardiac output and also it will compromise the systemic circulation. Systemic circulation will also be seen. Eventually, this will lead to the sudden cardiac death. Sudden cardiac death. Cardiogenic shock will be seen in this patient. So that's why what is the triad and treatment should be given. So the triad of this patient will be what we observe, Beck's triad. What does mean by the Beck's triad, guys? Hypotension, and muffled heart sounds because fluid is already on the all sides compressing. Muffled heart sounds and JVP raise. On the JVP waveforms, the Y descent is absent. Y descent is absent here. Next, there will be paradoxical pulse is also seen in this patient. Paradoxical pulse. This is what cardiac tamponade that you have to see. Whatever the pericarditis, the most common cause will be viral infections, that is commonly associated with the pericarditis. Even with the myocarditis, the most common cause will be viral infections only. Okay, viral infections is most common cause. Myocarditis can lead to the myocardial infarction, or patient can cause the sudden cardiac death. But this cannot be lead to the myocardial infarction, but it can lead to the constrictive pericarditis, recurrently attacks. This is the main difference that you have to take note. Next, moving on to the rheumatology section, guys. In the rheumatology, we are going to discuss between the osteoarthritis and the rheumatoid arthritis. Okay, osteoarthritis is a degenerative condition, whereas rheumatoid arthritis is a autoimmune condition. First thing that you have to remember. Okay, so what are the main causes? It is due to age, right? Degeneration is the cause. Coming to here, it is autoimmune condition. Also, it is a seropositive arthritis. Next, what about the age? Usually, this is affected more than 50 years of the age, whereas it is seen in the third and fourth decade of the life. Most commonly, it is going to affect the females, then males. Here also, more than females will be the common patients will be seen. Next, what is the most common joints that are involved? In the osteoarthritis, the most common will be carpals and also proximal interphalangeal joints and also distal interphalangeal joint. These are going to be involved. Here, the most common will be metacarpophalangeal joints, and the dip and pip is going to be spared. Okay, in the early stage, these are going to be spared, and always the whatever the joints that is involved in the osteoarthritis, those are asymmetric. Okay, those are asymmetric. And coming to the symmetric, the drugs that are involved in the rheumatoid arthritis is symmetric. What I am telling here you can see, here this is involved, but it is not involving in the other side. But if you see here, the both sides will be involved. So it is osteoarthritis is asymmetrical, whereas rheumatoid arthritis is symmetrical. Okay, first thing. Next, what about the improves with the work or the rest? The osteoarthritis will be worsened by the work. It will be worsening by work, whereas rheumatoid arthritis will improve by rest. It will improve by rest. Next, labs. On the labs is going to be normal. No antibodies is seen because it is a degenerative condition. But here on the labs, early the erythrocyte sedimentation rate, CRP, will be elevated. Along with that, anti-citrullated antibodies. These anti-citrullated antibodies will be positive, classically seen in the patients of the rheumatoid arthritis. On the X-ray, the changes of the osteoarthritis will be, you are going to see the osteophytes and also erosions mildly and reduced space. Okay, and capsule, that is whatever the capsule that is presented or the ligament will be reduced, seen in the osteoarthritis patient. Coming to the X-ray of the rheumatoid arthritis, you are going to see the erosions, which is aggregative, aggressive, and also joint narrowing is also seen here. Here you can see, this is how the cartilage, the capsule that is lost in the osteoarthritis, inflammation and erosion that is seen in the patients of the rheumatoid arthritis. Next, complications. Coming to the complications with the osteoarthritis, we are going to see the two types of the nodes. One is the Heberden nodes and other one is the Bouchard nodes. So in the Heberden nodes, it is going to involve the dip. Okay, HD. Remember this way. HD, it is going to involve the distal interphalangeal joints. And BP for the Bouchard notes, this is going to involve the hip joints. What is the drug of the choice in SAIDs is the first line of the treatment for the patients of the osteoarthritis. And next, coming to the patients of the rheumatoid arthritis, what is the complications here? You are going to see the two deformities. One is swan neck deformity and other one is the Botnier deformity. So what does mean by the swan neck deformity? It is going to cause pip will be extended, and dip will be flexed. This way, if this is your finger, so the dip joint is going to flexed and pip joint will be extended. So this is seen in the patients of the swan neck deformity. Next, patients with the Botnier defect, it is opposite to that. Pip will be flexed and dip will be extended. That means it is going to seen as this way. The dip will be extended, pip will be flexed. This is seen in this patient. What about the drug of the choice for this patient? DMARDs. This rheumatoid arthritis drug should be given for this patient. Commonly hydroxychloroquine that we are going to give. Next, rheumatoid arthritis will be associated with some of the syndromes. What is that? First one is the extra-articular involvement. The most commonly it is going to involve is the rheumatoid nodules. Rheumatoid nodules is commonly seen with the patients. This is the most common. And also uveitis and also rheumatoid sclerosis, especially in the eyes, cornea, that is going to involve, and some of the other syndromes. For example, Felty syndrome. What does it mean by the Felty syndrome? This is going to be rheumatoid arthritis plus pancytopenia and splenomegaly is seen in this patient. And also Kaplan syndrome. What does mean by the Kaplan syndrome? Rheumatoid arthritis plus anthracosis. Okay, that is seen in the Kaplan syndrome. This is what most commonly difference between the Felty and the Kaplan and the extra-articular involvement of the rheumatoid arthritis. Next, moving on to the gout. Right? In the gout, we have the three types. One is acute gout and other one is the chronic gout and pseudo gout. What are the joints that are involved here? Let's see. So the most commonly in the acute gout, there will be metatarsal joint, right? Your big toe will be involved. And that is also known as a podagra. Next, in the chronic gout, it is going to be knee. The most common will be knee. And in the pseudo gout also, the most commonly knee joint. And it is gout. Gout means we are going to check the uric acid. So the uric acid in the acute gout will be normal and uric acid in the chronic gout will be elevated and uric acid in the pseudo gout, it is normal. So what is the difference? So these two criteria from the gout is belongs to the true gout, whereas it is false gout. It is actually not gout, but it is metaphorically classified under the gout means it is a misnomer. What are those involved in this particularly gout and the pseudo gout? So in the gout, there will be increased of the urate deposits. Monosodium urate deposits is seen. In the pseudo gout, it is due to calcium pyrophosphate. Nothing to do with the urate crystals. So that is why it is misnomer given as a calcium pyrophosphate. What is the differentiation can we do? The differentiation will be under the microscopy, polar microscopy. When you are seen under the polar microscopy, you will be seeing this needle-shaped negative birefringence. Okay, needle-shaped negative birefringence seen in the patients of the true gout. Under the pseudo gout, you are going to see the rhomboid shapes, these kind of the rhomboid shapes, and those are positive birefringence that is seen in this patient. What about the drug of the choice? The drug of the choice for this patient will be NSAID. And the drug of the choice here is the allopurinol, xanthine oxidase inhibitor. And here the drug of the choice will be again NSAIDs. This is the treatment and protocol that you have to follow for the gout and pseudo gout. Systemic lupus erythematosus, right? This is the another condition, autoimmune condition that we are going to discuss here. So systemic lupus erythematosus, this is most commonly seen in the female patients, at least 8 times common in the females only because of the estrogen effect. So the more estrogen, the patients will be having the systemic lupus erythematosus, and this is considered as our type 3. It is going to be considered as a type 3 hypersensitivity reaction. And what are the other factors? Especially environmental and genetic condition also plays major role in the systemic lupus erythematosus condition. So coming to the symptoms, in the symptoms you are going to see the photosensitivity rash, butterfly rash. This rash is known as a malar rash, right? This is known as a malar rash. What does mean by the malar rash? Especially at the cheeks region you are going to see. This rash can be spare the nasolabial folds. This will spare the nasolabial fold and nose tip. Okay, nose tip also spared here. And how would the lesion that look like? The lesion will be raised and papular type of the rash you are going to see. And no itching, guys. No itching seen in the malar rash. And it will be triggered and increased with the sunlight. So photosensitivity is also seen. Next, coming to the brain CNS, patient will be having the revoking seizures, fever, and psychosis will be presented. Next, heart murmurs and Libman sac endocarditis will be also seen, and pleuritic chest pain is also seen in this patient. Kidneys is going to be the most common cause will be seen. This kidney failure, end stage renal disease also considered in this patient. Next, coming to the joints, arthritis will be presented and ulcers, recurrent ulcers will be presented. And coming to the hematology, pancytopenia is seen. Lungs, pleuritic chest pain, recurrent pneumonia, and infections will be presented. So all these will lead to the patient, all systemic involvement will be seen. So if the patient is going to die, the most common cause of death will be due to recurrent infections. Recurrent infection will be the most common cause for this patient. Next, coming to the antibodies, which is more important in the systemic lupus erythematosus. Not the symptoms, but the antibodies is very important. The most sensitive will be anti-nuclear antibodies. But these are sensitive for the lupus, but always it is seen in the all autoimmune condition. Then what is the specific one? The most specific is anti-Smith antibodies. And if it is going to be caused by the progression, what can be done for the disease progression? We are going to check the anti-double stranded DNA antibodies. We are going to check. But there will be drug-induced lupus also. In the drug-induced lupus, this will be antihistone antibodies. Next, neonatal also. From the mother, it can be transmitted to the children. Neonatal antibodies will be associated with the arrhythmias. So the positive antibody will be anti-Rho and anti-La. These are the antibodies associated with the neonatal. And how about the CNS? CNS patients will be anti-ribosomal P and anti-neuronal antibodies will be associated with the CNS. Okay, these are the important antibodies that you have to know. If the patient is having the recurrent abortions, so that means SLE patient also suffering from the APLA syndrome, antiphospholipid syndrome that is associated. Here, the cardiolipin antibodies will be positive in this patient. What is the drug of the choice for this patient? The drug of the choice will be hydroxychloroquine. hydroxychloroquine should be given for this patient, right? Recurrently, the patient will be suffering from the infections. You have to treat the underlying causes also. Next, what are the drugs that are causing the lupus, triggering the lupus? Remember by the mnemonic SHIP. Sulfur drugs, sulfadoxine, these kind of the drugs will be involved, and hydralazine, isoniazid, and procainamide. These are the drugs that will be associated with the drug-induced lupus. Next, moving on to the another ankylosing spondylitis autoimmune condition. This is known for the seronegative arthritis associated with the HLA B27 positive. Okay, first thing that you have to understand. And who is the patients that are involved? Most commonly, it is going to involve the males, those who are in the 20s and 30s age. Okay, then what about the condition that is triggering here? It is the autoimmune condition that is triggering, and the patient symptoms will be morning stiffness. So early morning there will be stiffness which will be lasting more than 30 minutes. Okay, this is the first diagnostic sign that you have to understand clinically, and that pain will be increased by the rest and decreased by the work. So improvement will be seen with the work only. First thing. And next, if it is progressed, it will cause the bilateral sacroiliitis and also ankylosing. Slowly, it is going to cause the all main joints will be disturbed in these patients. Okay. What are the tests that we are going to perform here? The test commonly done as a physical examination, Scober test. Okay. In the Scober test, we ask the patient to bend forward. So when they bend forward, the flexion, when we are flexing the hip, this flexion is decreased. So this is positive for the ankylosing spondylitis. Okay, and it can also involve the extra articular. And in the extra articular, the most common will be uveitis. Uveitis, anterior segment will be involved in this patient. The drug of the choice for this patient is the NSAIDs, is the treatment of the choice. On the X-ray, you are going to see this classical sign. This is known as a bamboo spine. This is classically seen in the patient of ankylosing spondylitis and sacroiliitis, right? Here you are going to see the sacroiliitis. And this is the classical condition of the patients. And classically another sign, here you can see this is how the question mark posture will be seen. Okay, question mark posture seen in the patients of the ankylosing spondylitis. Next, moving on to the another syndrome, guys. This is systemic scleroderma. Okay, what does mean by the systemic scleroderma? Systemic scleroderma is autoimmune condition and chronic condition. And what happens in this condition is there will be a vasculopathy. Okay, so the vasculopathy will involve the capillaries. All the capillaries will be involved. So this will cause the vasculitis. This inflammation lead to vasculitis, and over the time recurrent vasculitis will lead to fibrosis, and fibrosis will lead to sclerosis. Okay, and this condition is irreversible. Only reversible is the vasculitis, but this vasculitis phase will be asymptomatic, which will be lead to the irreversible stage of the sclerosis of the scleroderma. And scleroderma is divided into the diffuse type, and another one is the crest syndrome. So first we will see the crest syndrome. So this is what the crest syndrome. Mnemonic itself will tell crest will be associated with the types of the crest syndrome. First, C for calcinosis. So this is the how picture will be the hardening of the capillaries, nail capillaries and the finger capillaries. That is calcinosis. Raynaud phenomena. Raynaud phenomena means the pallor and the circulation. The differentiation can be seen. and esophageal dysmotility and sclerodactyly. The fingers will be hardening and telangiectasia. So you are going to see the blood vessels, the venous capillaries will be clearly visible. This is what the crust syndrome. What about the diffuse one? So in the diffuse one, it is going to mainly involve the skin. So on the skin, you are going to see the hardening of the facial structures. So that one we call as a mask of faces. Mask of faces and salt and pepper appearance. Salt and pepper appearance. It is also going to involve the lungs, which will cause the pulmonary hypertension, and also involve the kidney, which will cause the end-stage renal disease, and also pulmonary hypertension can be triggered that will cause the death of the patient, okay, which will be leading to the left ventricular hypertrophy and the heart failure. So this is commonly seen with the scleroderma patient. Next, whatever the antibodies that you have to remember here, the antibodies for the diffuse type is anti-topiosomere is positive. Okay, and also another one is the anti-SCL70 antibody that is positive here. Next, coming to the crust syndrome, anti-centromere. Anti-centromere is positive. C for C, C for C. Okay, anti-centromere. The treatment will be supportive treatment only. For example, steroids to compress the autoimmunity, pulmonary hypertension, vasodilators. So like that, supportive treatment should be given for this patient. Next, coming to the, here the picture. So this patient is suffering from the milkless disease. Okay, milkless disease. What does mean by the milkless disease? How many of you heard of this disease, guys? So milkless disease is nothing but it is a Sjogren's disease. Okay, it is Sjogren's disease. Sjogren's disease is a slow and chronic autoimmune condition. How it can be slow, so it can even damage and cause the neoplasia. That kind of disease is the Sjogren's disease. It is associated with the HLA-DQ4. Most commonly, females will be involved rather than the males. And what are the symptoms? The patient will be having the xerophthalmia, so dry eyes, xerostomia, and also zero trachea. So whichever the smooth surfaces will be with the filled with the fluid will going to be the dry. So this is seen in this patient. For the xerophthalmia, the test that we are going to conduct is the Schirmer's test. Okay, Schirmer's test we are going to perform for this patient to check the dry eyes and dryness of the eyes. And also parotids. Parotids is going to be involved in this patient, and also orchitis, whatever the glands that is present in our body also going to involve. Antibodies is anti-SSA and anti-SSB. Antibodies are positive for this patient. And if it is progressed, as we discussed, the progressed will be lymphoma. The lymphoma is associated with this patient. Cancer is going to be triggered. All right, the treatment of this patient will be steroids. Is the treatment for this patient. And see here you can observe the constitutional symptoms will be weight loss, night sweats, and also glandular parotid glands going to be swelling, and pulmonary bronchitis, lung disease will be seen. Lymph nodes will be causing the lymphoma. Renal will be associated with the vasculitis and glomerulonephritis. Articular recurrent arthralgia, muscular is going to involve the myositis. Peripheral neuropathy and cutaneous purpura and the subcutaneous lupus will be also seen in this patient. This is known as a Sjogren's or the milkless disease. And these are some of the important topics of your rheumatology. In the respiratory system, the first from this picture only you can understand there will be the normal airway, and once it is triggered, it is causing the asthmatic airway due to bronchoconstriction, right? The muscles, which are the smooth muscles that is present here, is constricted and obstructed, which will be causing the asthma, right? So let's see, what is asthma? Asthma is an hyper-responsive condition. It is hyper-responsive condition, chronic obstructive disease, right? So what happening in the patients with the obstructive airway of this patient? usually due to the triggering of the allergic, for example, IgE mediated, or the patients with the inflammation due to triggering factors like obesity or exercise, leading to the asthma, obstructive constriction of the bronchoconstriction. This is the main thing that we have to understand. Then asthma is most commonly in which population? Most commonly in the children. Children are most affected. With the help of IgE, you say, or atopy, other condition, the children are more prone to this condition. Let's see the two different types of the asthma. Type 2 and non-type 2. So type 2 asthma will be allergy. Okay, it is a allergic type and IgE mediated type of the asthma. So what are the triggering factors? Interleukin 5 and interleukin 4. Interleukin 5 will help to release the eosinophils and 4 will help in the release of the mast cells, which will further release the B cells and causing this condition. All right, next non-type 2 is going to be inflammatory type. The most common will be type 2 only on general population. Type non-type 2 is very rare and it is associated with the T helper 1 and T helper 17. Okay, these both are going to be the chronic. Chronicity will be seen with the non-type 2 and interleukin 17, interleukin 6 and interleukin 1. All these are going to be cause the release of neutrophils and inflammation. So this is the that we can do for this patient. So the common test that we are going to perform is the gold standard spirometry. Gold standard spirometry we are going to see in this patient. Once the spirometry confirms there is an obstruction, then we can go for the expiration test. Okay. And forced expiration at 1 second we are going to check. In this, the patients will be positive for 0.7 or the 70% of the decreased airway. So this is the positive for the patients of the asthma. Then we are going to add the SAMA, the short acting muscarinic agent that we are going to add for this patient. So when this is added, the after you check the FEV1 by FEC, you are going to see there will be improvement of more than 12%. So the improvement is seen. So that means the asthma which is present here is a reversible. It is reversible obstruction. So the major differentiation between the COPD and the asthma is reversible obstruction with the therapy. That is, you have to understand from this functional vital test. Okay. Next, moving on to the treatment. For the treatment, we are going to use the JINA guidelines, and in the JINA guidelines, you have to approach the stepwise approach. Okay, stepwise approach is important for this patient. Next, JINA guidelines, what is explaining here? So the JINA guidelines is telling if the patient is having more than 4 attacks, or the patient is having more than 1 episode per night, then you have to go extensively for this patient. Okay, to choose this patient, what is the next test? You are going to conduct the FEV1 by FEC. And if it's FEV1 by FEVC, so you have seen the improvement more than 30% or equal to 30%, then the treatment will be low dose of inhaled corticosteroids, along with that long-acting beta agents. Okay, long-acting beta agents that you are going to give for this patient. Next, same again, the approach is same. If the patient is having the more attacks per week or more 1 episode per night, this patient FEV1 by FEVC. So if it is still less than 30% without improvement, then you have to go for the medium dose of inhaled corticosteroids at the plus LABA agents. And if it is still not improving, then we can go for the step approach, that is called as a step ladder pattern. In the step ladder pattern, either you are going to add the other drugs or double the dosage. Okay, either you are going to add the drugs or the double the dosage. Next, we have the monoclonal antibodies also. So the monoclonal antibodies that is present here. First one is the omalizumab. This is going to help to IgA target. Okay, it is going to be IgA target. Next, you also have the mepolizumab. Is going to the interleukin 5. Okay, next dupalizumab. Okay, dupalizumab. This dupalizumab is going to be act on the IL-4 receptor. Okay, next, fourth one. Remember, this is tezepelumab, monoclonal antibody, involve the TSLP, thymic region, right? Thymic stimulating factor, it is going to block. So these are the important one that you have to remember. T, A, B, C, D, fourth one, T for T, omali, emali, IgE, M, IL-5. Remember that way. These are the important factors that you have to take note of it. Next, moving on to the COPD. COPD is actually irreversible condition. Same, why it is a irreversible obstructive disease? It is going to involve the two factors. One is emphysema and other one is the chronic bronchitis. What does mean by the chronic bronchitis? And when you call this as a chronic bronchitis, the patient will be suffering from the chronic cough and it is not decreased either by the congestants or decongestants or the suppressants. So this patient is suffering from this cough. How many months? At least this patient is suffering from more than equal to 3 months continuously, despite of the treatment, at least 2 consecutive years. At least 2 consecutive years, this patient is suffering from the chronic cough, which will lead to the recurrent bronchial regions to inflamed. Next, emphysema. What does mean by the emphysema? Emphysema is dilatation of the alveoli. Once this dilatation reach the limit, they're going to collapse. So the collapsed airway with the alveoli, which will be leading to the emphysema. Emphysema is 4 types. One is central, and the one is the pancinal. Third one is the preseptal, and last regular. These are the 4 types. Let's see the differentiation between these each. So the central one is the most common overall. It will involve the upper lobe of the lung. Most commonly seen among the smokers. Second most common. Panisnar is the second most common, seen with the P in the lower lobe. Patients. Going to see. Next, preseptal is going to involve the lower lobe. Spontaneous pneumothorax. Next, irregular one. Histopathology. You are going to see this as a histopathology. Irregularity will be seen in the structure. That is what the irregularity. Next, how can you see this one? The structures will be the central one. This is the normal structure of our acini. This is the normal structure of the acini, guys. So in the central one, it is going to be like this. So the central one is going to be the dilated, one is the dilated and the distal region will be normal. Next, pan-acinar. So entire structure will be dilated. Preseptal. So only segmental. At some point of the segment will be dilated and some point of the segment will be normal. That is seen in the preseptal. Irregularity, you can understand that is going to be irregularity will be seen randomly. That is the irregular one. So this is how emphysema will be presented, and that's how the chronic bronchitis. If these both are together, then it is going to cause the chronic obstructive pulmonary disease. What is the most common cause? The most common cause will be smoking. So is every smoker having the COPD? No. At least this patient will be having the history of one pack for 24 hours and at least 30 years of the history. And the second most common, if the females is involved, that is due to biofuel gas or the biofuel mass, that is going to be the second most common. Next, we have the specific criteria for this patient, that is gold criteria. What does mean by this gold criteria? When you're doing the checking of the fractional expiration value, when you are going to check, you are going to see these different stages. So all the patients obstructive with the 0.7 only. And if it is predated, gold 1 will be more than 80%, gold 2 will be 50 to 80%, gold 3 will be more than, less than 30 to 50%, and severe will be less than 50%. So this is how we are going to check the gold criteria. This is very important for this patient. Next, also there will be another question. What is the best treatment? What is the best treatment for this patient? The best treatment will be oxygen. The oxygen therapy should be given at least more than 14 hours per 24 hours. You should give. Okay. This is the best treatment that is going to help the patients with the chronic obstructive pulmonary disease. Next, what about the treatment protocol for this patient? So the treatment protocol for this patient will be, if the patient is having the history of more than 2 years, the patient is treating with the respiratory distress. So more episodes and 2 episodes in 1 year. He was treated with the medically conservative treatment is given, or more than one episode in last 1 year, patient is treated with the respiratory distress. Okay, with the respiratory distress. So for this patient, if yes, then this patient is going to be treated aggressively. Okay. So muscarinic, both will be given at high dosage. If no, then you have the other two categories, grade 1 and grade 1 patients will be either the stages will be of the gold stage 1 or the gold stage 1. Those patients, we are going to give only mild dosage. Okay, mild LAMA is enough. Grade 2, this patient is actually in the category of the moderate. Then we are going to start with the LAMA plus LABA. Let's start with the next topic. This is the restrictive lung diseases. So in the restrictive lung diseases, the most common one will be idiopathic pulmonary fibrosis. So in this idiopathic pulmonary fibrosis, the most commonly seen among the males with the history of the smoking, and also some of them will be associated with the genetic conditions, right? This is the one of the thing that you have to remember. And next, on the auscultation, you are going to listen to the velcro crackles. Velcro crackles will be heard, and also crepitus on the percussion will be seen. When the investigation of the choice will be HRCT, and on the HRCT you are going to see honeycomb pattern and multiple bronchiectasis will be seen in this patient. What is the treatment of the choice? The drug of the choice for this patient will be antifibrotic drug. So ninatinib, this drug can be given as a drug of the choice, but treatment of the choice will be lung transplant. Treatment of the choice will be lung transplant should be done for this patient. Next, here comes the another picture. The condition is bronchiectasis. So this bronchiectasis is usually chronic, irreversible, obstructive disease. Okay, it's an obstructive disease, guys. So what is the main thing of the bronchiectasis? So there will be on the HRCT, you are going to see this is due to most commonly post-infection. So when there will be the post-infection, the dilatation and the destruction of the bronchioles will be seen in this patient. So that will be leading to the bronchiectasis kind of condition. So this patient on the HRCT, you are going to see signet ring and also tram track appearance. Tram track appearance will be seen in this patient. Other conditions like cystic fibrosis and pulmonary abscesses. Also, primary ciliary dyskinesia. Patient is also seen with this condition. Primary ciliary dyskinesia and Cartagena syndrome. So this patient also associated with the bronchiectasis. And ciliary dyskinesia, you have to know about the triad. The triad is mainly about the defect of the cilia. So cilia is defected. This patient will be having the bronchiectasis, one thing, and also dextrocardia. So the cardiac should be on the left side, but it is seen in the right side of the patient. Next, another one will be infertility. Infertility, most commonly males than the female. So this is seen in the patients of the primary ciliary dyskinesia. Next, moving on to the ARDS. Okay, acute respiratory distress syndrome. So these acute respiratory distress syndrome most commonly seen in the which patients? Before we get to know about the what is acute respiratory distress syndrome, we will see what is the triggering factor that is happening to the acute respiratory distress syndrome. That is respiratory failure. So respiratory failure is two types, type 1 and type 2. So type 1 will be most commonly due to decreased oxygen, hypoxia. Okay, type 2 is due to more CO2 retention, hypercarbia. So type 1 is seen in the patients of the pneumonia, and type 2 most commonly seen in the patients of the COPD. So if it is a hypoxia, then we can treat this patient with the oxygen, right? Oxygen. And this patient we can have to treat with the oxygen, but in the BiPAP mode. In the BiPAP mode, we have to treat. Even though it is a hypercarbia and the oxygen is normal, we have to attach the BiPAP for this patient. Next, moving on to the ARDS. ARDS is a complication of pneumonia. Most commonly, this is due to pneumonia, which will eventually lead to your type 1 heart failure, type 1 respiratory failure, right? So what is happening in the ARDS? ARDS is going to it is going to damage the type 1 and type 2 pneumocytes. These cells will be damaged. So this destruction will cause the acute inflammation. And furtherly, it is also going to damage the surfactant. And all this will lead to the edema and neutrophil infiltration, right? Acute inflammation. So this is going to damage the lung parenchyma of our due to the infection. So what is the criteria that we follow? That is Berlin criteria. Okay, Berlin criteria we are going to follow. In the Berlin criteria, the timing on the onset should be less than 7 days, and pulmonary edema it should be from the only from the our lungs, not from the cardiogenic. Radiological features should show the bilateral infiltrates, and hypoxia mild will be FiO2 200 to 300, moderate 100 to 200, and severe will be less than 100. Then what is the treatment of the choice for this patient? The treatment will be mechanical ventilation, and mechanical ventilation settings will be tidal volume should be less than 6 mg per kg, and next coming to the PEEP, it should be more, so it should be increased from the normal pressures. And also you have to check this patient FiO2 maintain at less than 60%. This is the therapy that you have to give for this patient. Okay, 6 ml, sorry. So this is how the mechanical ventilation should be, settings should be maintained for this patients. Next, moving on to the curve 65 scoring. In the curve 65 scoring, this is used for the patients of the pneumonia. What is this curve 65? C for confusion, U for urea more than 7 mol, and R for respiratory rate more than 30%, 30 breaths per minute, and systolic hypotension will be C. 65 is for the age of the patient. Each one will be given 1 point, and we are going to risk stratification. Risk criteria we are going to see. For example, patient is having the 0 to 1 score only, then you can give the antibiotics and send for the outpatient care at OPD only. And if the patient is having the equal to 2, then it is likely to be you have to admit the patient and admit in the absorption ward or the general ward. If it is more than or equal to, definitely you have to admit the patient in the ICU and you have to treat completely until the recovery, then only you have to discharge. This is what curve 65 scoring. Next, coming to the pneumonia, in the pneumonia, you have the different types. For example, atypical pneumonia. Atypical pneumonia, the most common cause will be mycoplasma. Right? Nematoceles. Nematoceles. This is seen in the Staph aureus. And immunocompromised. Immunocompromised. This patient you are going to see pneumocystis. Okay, alcoholics. You are going to see the Klebsiella. But overall, the most common will be strep pneumoniae is the most common cause, right? Next, if it is hospital, if it is from the hospital, then it is Staph aureus again. But ventilator related will be Pseudomonas. Ventilator will be Pseudomonas. And most common cause of the sepsis or the septic shock, the most common cause will be pneumonia only. Okay, these are the points that you have to remember, and direct MCQs can be asked here. Next, we are going to see the lights criteria seen in the patients of the pleural effusion, right? And in this pleural effusion, you have the 3 different parameters. One is the serum protein versus the pleural protein, 0.5 more than 0.5. Another one is the pleural fluid LDH and the serum LDH more than 6, and only pleural LDH which will be equal to more than 2/3 of the upper limit of the serum LDH. Any one is positive, then we can consider this as a exudative from the infection region, right? Even if it's none of are met, then it is classified as a transudative. That is what lights criteria that you have to understand. Next, moving on to the cystic fibrosis. Okay, cystic fibrosis. Cystic fibrosis is going to involve the CFTR gene mutation. Okay, it is an autosomal recessive condition. Autosomal recessive condition. Most commonly, males are involved than the females, and these autosomal recessive, this gene will be seen on the chromosome 7q. It is where the cystic fibrosis will be affected. What is the cystic fibrosis mainly? So when the patients are affected with the CFTR, the chloride channel transport will be damaged. What happens? The chloride will be decreased and sodium will be increased. So this mixture will cause thick, viscous mucus production, and jitteriness will be seen. Okay, very, very thick mucus, which will be eventually lead to the obstruction and infections. Is the CFTR, is the cystic fibrosis will affect only one organ? It will involve the multiple organs. Okay, first one and the most common will be lungs, followed by the GIT, pancreas. Okay, and also it is going to involve the endocrine. Okay, islets, pancreas islets will be damaged, and also infertility seen with this patient. Cystic fibrosis. What is the test then? The best test that you can going to do is the sweat chloride test for 2 occasions. Okay, 2 occasions it should be positive. More than 60 millimoles per liter, it should be positive for the 2 occasions. Then only it is considered as a gold standard for the patient. And the cause of death will be infection. Okay, cause of death will be infections and respiratory failure. The drugs we are commonly used in these patients will be supportive treatment only. Supportive treatment. But nowadays we are using the CFTR modulators. Example, ivacaftor. Okay. The drug which will end with the caftor will be the CFTR modulators. Right. Next, moving on to here the picture, we can understand. So I will give the example of this case. For example, let's see. The patient is having the condition with the fever, weight loss, and cough, recurrent cough, and night sweats. So based on these symptoms, usually we are going to do the cough, fever, then we are going to order the patient with the chest X-ray. Okay, then the chest X-ray is done. Now here you can see this is the adenopathy. So bilateral lymph adenopathy in the hilar region, you are going to see. This is also positive. Then if you done the histopathology of this patient, you by this time only you have the differential diagnosis TB. But histopathology is turned out to be non-caseous necrosis. But TB will show the caseous necrosis, right? So this condition is commonly associated with the sarcoidosis. Okay, sarcoidosis, same features of the TB. So it is not a TB, it is actually sarcoidosis. So this is the skin manifestation of the sarcoidosis known as a erythema nodosum. Erythema nodosum. Sarcoidosis, what is meant by the sarcoidosis? It is a idiopathic chronic autoimmune condition. Okay, and this is known as a scarring staging, guys. The staging of the chest X-ray is known as a scarring staging. So the first stage, you are going to see the bilateral hilar lymphadenopathy, but normal parenchyma, right? This is the only adenopathy. Next, hilar lymphadenopathy along with the pulmonary infiltration. Okay, along with that, pulmonary infiltration will be seen. Third one, only infiltration will be seen. And the fourth stage, irreversible damage was already done. Irreversible damage was already done. This will be pulmonary fibrosis. Okay, very important staging that you have to remember. Next, what are the other systems will be affected here? So sarcoidosis will also involve the facial nerve, parotid gland. On the parotid, if you do the scanning, especially PET scan, you are going to see the panda sign. And also it will be involving the skin, cardiac. In the cardiac, you are going to see the dilated cardiomyopathy, right? So if it is a tachyarrhythmias, the sudden cause of death will be seen in this patient. Okay, sudden death. These are the other features. Coming to the test. On the test, serum calcium will be elevated. ACE levels will be elevated. CD4, CD8 ratio will be elevated. So this is classically seen in only one condition, that is the sarcoidosis. Next, coming to the treatment, steroids and immunosuppressants. And also multiple monoclonal antibodies can be also given for this patient. The most common cause of death will be obviously respiratory failure. Okay, this is the one thing that you have to remember. Next, here the classical picture, tuberculosis, right? What is this one, guys? This is known as a Gons focus, and these are the hilar lymphadenopathy, hilar lymphadenopathy. And if it is together, then we call this as a Gons complex, Gons complex, right? On the histopathology, you are going to see this, you are going to see the caseous necrosis, caseous necrosis or the granuloma you are going to see, right? What is the most common cause of the tuberculosis? Mycobacterium tuberculosis. Mycobacterium tuberculosis, which is known as a acid fast bacilli and obligate aerobe. Obligate aerobe. This mycobacterium cell wall will contain the specific cells, that is mycolic acids. Mycolic acids. Same, another symptoms is same. Fever, especially in the evenings, cough with sputum. Patient will be having the significant weight loss and also night sweats. These are the symptoms that is commonly seen in this patient, right? Next, what is the test that we can do for this patient then? The best test you can do is the CBNAT. Why CBNAT is important? Because it is going to show the resistance also. The drug resistance can also be seen. Whatever the treatment of this patient, remember isoniazid, rifampicin, and ethambutol, and pyrazinamide. Right? These are the 4 drugs that we are going to give for this patient for at least 6 months. 6 months treatment that we are going to give for this patient. And coming to this one, this is secondary TB due to reactivation. Okay, reactivation. What is this? All infiltrates. This is known as a miliary TB. Primary, secondary cause, the cause of this one will be hematogenous spread. Hematogenous spread. TB does not only going to involve the lungs, it will involve multiple. For example, it is involving the spine. It is known as a Pott's spine. Okay. Secondary TB most commonly seen in the lymph nodes. It is also going to involve the skin, where you call this as a lupus vulgaris. Right? It will involve almost all the organs. It will also involve the ileus TB, putty kidney, in the kidney. So there are multiple manifestations of the TB that will be seen. This is the overview of the TB. Let's move on to the today's last system, that is kidney. Okay. So first, whenever you see the kidney, you have to understand this is also one of the major organ for the intravascular system. Okay. Even if it is reduced also, most of our filtration unit will be disturbed and our system will be deteriorated from the kidney itself. So first thing you have to know, the internal structure of the kidney will be contains of the 1 to 2 millions of the nephrons. So what does this nephrons will do? They will maintain the GFR. Okay, they will maintain our glomerular filtration rate with the help of what? Filtration unit. Okay, with the help of filtration unit. What does this filtration units will be containing? Basement membrane. They will contain the basement membrane and visceral epithelium, podocytes, and also endothelium. These are the important factors that is going to affect, important for our glomerular filtration. So, but if there is a chance that if we lost the, with the help of, if we lost the protein from our body, what we are going to test? Urinary albumin creatinine ratio you are going to do. So in this, if you see less than 30 milligrams is lost, it is normal. If it is more than 30 to 8, more than 30 to 300, then it is known as a microalbuminuria. Microalbuminuria loss. And if it is more than 300, then it is known as a macroalbuminuria. microalbuminuria loss of the in the urine. This is what we have to check for the conditions. Next, moving on to the first condition. This is known as a renal artery stenosis. Renal artery stenosis. What is the most common cause for this one? The most common cause is atherosclerosis. Second most common will be genetic, that is fibrovascular dysplasia. Fibrovascular dysplasia. This is the second most common. And how these patients are going to present it? Hypertension, that two recurrent attacks, and which will be turned out to be resistant hypertension. And flank pain, false flank pain will be presented, and urinary problems will be also seen. Right? On the test, you are going to see serum creatinine ratio will be raised. Serum creatinine ratio will be raised in this patient. Next, what is the best test that you are going to do in this patient? The screening will be done by ultrasound. Ultrasound Doppler should be done. Okay. On the Doppler, you are going to see the proximal will be, okay, proximal will be blocked. Okay, proximal will be blocked in the most of the times. Distal will be normal. Distal will be normal in this patient. This is what renal artery stenosis. And other than that, you are also going to see the beaded appearance. Beaded appearance will be seen on the ultrasound. Next, this is the investigation of the choice known as a angiography. Ultimately, you have to do the angiography. What is the treatment, guys? The treatment will be, if it is bilateral, don't give the ACE inhibitors. Okay, if it is a unilateral, then ACE inhibitors can be given. Okay, that is the one thing that you have to remember. Along with that, diuretics for the normal renal function to get back, and also calcium channel blockers. This triple therapy should be given for this patient. The treatment of the choice will be stenting. Stenting should be done for the treatment of the choice. Next, moving on to the renal tubular acidosis. We have the three types, right? One is type 1, type 2, and type 4. Okay, type 1, type 2, type 4. Type 3 is not mentioned, that is not even discovered as of now. So the type 1 renal tubular acidosis, RTS. So this is seen in the distal convoluted tubule, and this is seen in the proximal convoluted tubule, and type 4 is seen in the collective tubule. Okay, then which is the most common? Type 4 is the most common among all. And what are the causes? The causes will be, all the arterias will be seen in the multiple myeloma patients. Okay, multiple myeloma and also multiple myeloma. And diabetes mellitus or the diabetic nephropathy will be seen. Other causes here will be the amphotericin B, and here Fanconi syndrome, and here diabetes mellitus. What happening here? Let's see. So the distal convoluted tubule is affected in the type 1. So what happens in the distal convoluted tubule? You will be having the sodium reabsorption will be decreased. Along with that, chloride absorption will be also decreased. And also H plus ions secretion, they should go out. That is also going to decrease. So all these dysfunction will be seen in this patient. So what happens when you check the urinary pH? Here it is not going out. So that will be increasing here. So urinary pH will be increased in this patient. Okay, urinary pH will be increased in this patient. And both patients, when the patient is having the sodium is going to out, and what happens? It will trigger the aldosterone. So aldosterone will start to increase the sodium with the water. So it will further decrease the potassium. So what you are going to see here, hypokalemia. This is also important point for our examination. Next, moving on to the type 2 arteriae. This one is going to cause the HCO3 defect. HCO3 carbonate, the bicarbonate defect will be seen in this patient. Again, further, if the bicarbonate is disturbed, then again aldosterone is going to start acting. So this will further, Na will increase, water will be increased, and again potassium will be decreased. So here also you are going to see the hypokalemia. And urinary pH will be also going to be acidic. Next, coming to the most common one that is seen in the collecting tubule associated with the multiple myeloma or the diabetes mellitus patient. What happened here? It is directly affected the collecting tubule. So aldosterone or the ENaC channels is going to decrease. So the function is not properly occurring here. So that will cause the sodium to decrease, water to decrease. Along with that, there will be increasing of the potassium. So hyperkalemia associated arteriae, that is the type 4. And urinary pH again here is going to be acidic. So these are the different points that you have to take note in the RTAs. All right, next. Next, moving on to the some of the syndromes that you have to remember according to this. Here it is a proximal convoluted tubule. If it is a genetically associated, then proximal convoluted tubule will be having the Fanconi syndrome. Next, here it is the thick ascending loop. If it is a thick ascending loop, here you are going to see the Bartter syndrome. Here you are going to see the Bartter syndrome and the distal convoluted tubule. If it is a distal convoluted tubule, you are going to see the Gitelman syndrome. Gitelman syndrome. On the collecting tubule, Liddle syndrome. Liddle syndrome will be seen. What does they going to affect, guys? If it is a PCT, Fanconi syndrome, type 1 arteria you are going to see. And also almost 80% of the filtration will be decreased. Bartter syndrome, sodium, potassium, chloride. The absorption will be decreased. Gitelman, you are going to see the sodium and calcium. Reabsorption will be decreased. Liddle syndrome, renin activity. Renin activity will be disturbed along with the aldosterone. So let's continue with the another picture here. So same the nephron structure and their tubules. So again here we are going to understand where are the major drugs are going to act here. So here at the proximal convoluted tubule, we have carbonic anhydrase inhibitors, right? Carbonic anhydrase inhibitors. And next at the loop diuretics, here at the descending loop of Henle, we are going to see the osmotics. And thick ascending loop, here loop diuretics will be acting. Distal convoluted tubule, thiazides. And convoluted tubule, you are going to have the potassium sparing drugs. Potassium sparing drugs. So let's see in short, even in our pharmacology chapter also we have discussed. So in short, once again, I am going to cover for you guys carbonic anhydrase drugs. Inhibitors. One of the examples will be acetazolamide. Acetazolamide. So acetazolamide we are going to use most commonly for the closure glaucoma and high altitude sickness. Right? High altitude sickness. The side effects of this will be metabolic acidosis and also stones, renal stones, and sulfa allergy is contraindicated. Sulfa allergy will be contraindicated for these patients to give the drugs. Renal failure also we should not give. Next one, osmotics. Example, mannitol. Where we are going to use the mannitol? Cerebral edema, and also patients with the increased intracranial pressure. All the trauma cases we are going to use. Even in the patients of the renal failure also, we can use this drug. And osmotics are not given in the patients of the pulmonary edema. So pulmonary edema patients, this drug is contraindicated. And third one are loop diuretics, furosemide, one of the drug. Furosemide can be given in the patients of the pulmonary edema and also with the patients, those who are suffering from the hypertension, we can give this drug. But it should not be given in the patients of the cerebral edema. Okay, cerebral edema, it is contraindicated, vice versa with the osmotics. What are the side effects of this drug? Loops lose everything. So loop lose all. So sodium will be decreased, potassium, H plus ion, magnesium, calcium, and also chloride. So loop lose going to everything. And also increase the glucose, increase the uric acid. Next one. Thiazides. Thiazides. Thiazides also act as the same thing, but they all the drugs are going to end with the thiazide name itself. So, but they what they do means they lose every ion, every electron except the calcium. So calcium will be normal. Remaining all sodium, potassium, magnesium will be decreased and also chloride. But calcium will be normal in this patient. Next, what are the uses? Nephrogenic, diabetic insipidus, and also renal failure, and also those who are suffering from the hypertension. We can give this drug. Side effects will be calcium normal, remaining all will be decreased. Same again, this is also going to increase the glucose, also increase the uric acid for the patients. Next, fifth one is going to divide into the two types of the drugs. One is the potassium sparing and other one is the INAC channel blockers. Okay, INAC channel blockers. So what are the example? One is the spironolactone. Spironolactone used in the ascites and also resistant hypertension, right? Next, INAC channel blockers. What is the drug, guys? Amyloid. And the side effects of this patient, these drugs will be, the patient will be, those who are taking the spironolactone, there is a high risk they can produce, they can have the gynecomastia. And they also act on the INAC channel blockers. They can also cause the low libido, will be seen in this patient. Next, loop diuretics, another point also you have to remember, it is ototoxic drugs. Okay, they are the ototoxic drugs. Next, moving on to the chronic kidney disease and the acute kidney injury. So the first one, acute kidney injury, you have to know most common cause. Most common cause will be sepsis, guys, due to decreased vascularity, right? So overall, the tissue perfusion will be decreased due to the sepsis. So that is the most common cause. So the most common will be pre-renal, and in that pre-renal, the most common will be sepsis. First point that you have to remember. So the pre-renal will be before the renal only. And next, within the renal, intrinsic renal, the common causes will be like drugs and toxins. Same again, drugs and toxins, which will be the most common. Next, post-renal. Here it is post-renal obstruction like hyperplasia or the stenosis, prostatic cancer or the urinary calculi. These are going to be the post-renal causes. Next, you have the two criteria, refill criteria and the Akin criteria. Akin criteria is most important. So how can you remember this? Stage 1, the creatinine will be increased by 1.5 and urinary output will be decreased. Stage 2, it will be increased by the 2 times. Again, urinary output will be decreased. Stage 3, 3 times increasing the creatinine and 0.3 ml of the only per kg will be decreased to the patients of the acute kidney injury. And what you have to treat in this patient? Treat the underlying cause. So that is the only treatment that we can do for this patient. Next, coming to the chronic kidney disease. So the chronic kidney disease, most common cause will be diabetic nephropathy. Okay, it is going to be diabetic nephropathy, most common cause. So then overall, Other cause will be multiple myeloma. Before that, it is a multiple myeloma, but now due to diabetic most probability that will be the most common cause. So you have to test this patient. If the patient is type 1 diabetic, less than 5 years, the progression will be seen. So you have to monitor the diabetic status. Next, type 2 diabetes mellitus, the risk will be less than 10 years. So the monitoring is very important for this patient. Next, diabetic nephropathy or the patient, those who are suffering from the CKD, what is the effect? So the CKD effects will be majorly seen on the nephrotic condition. So the nephron, the GFR will be decreased in this patient. And if the GFR is decreased, it is indirectly affect the parathyroid hormone due to calcium is going to decrease in the kidney. And this is also indirectly affect the vitamin D, right? Vitamin D also decreased. And this metabolism is already disturbed. Already the elements that is present in our body, potassium, sodium, and magnesium, all these phosphorus is going to disturb. All this will be leading to the multiple organ disease of this patient. So ultimately, when these stages are increasing, for example, you are going to see the normal GFR for us will be the 125. But for the first stage, it is already 90 ml per minute. That is can be treated as early as possible. Stage 2, it is already decreased 60 to 89. So this patient is going to need the supportive treatment. And stage 3 is 30 to 59. And stage 4, this patient also 15 to 29. Stage 5 is almost less than 15. So all these patients are need to be get the hemodialysis. These patients are needed to get the hemodialysis, because if it is not treated early, they can land up into the end stage renal disease. End stage renal disease they are going to lead. And hemodialysis can be treated in the two types. One is the AV graft, with the help of the AV graft, and other one is the peritoneal. Okay, with the help of the ultrafiltration system, we are going to do the dialysis. What is the most common cause of the side effect with the hemodialysis? Hypotension. Hypotension will be the most common cause. What about the treatment of this patient? The treatment for the CKD is always supportive. So always supportive. We are going to start this patient on the different types of the drugs along with the hemodialysis. You have to treat the underlying cause and at the same time, whatever the metabolism that is disturbing by the kidney, right? If the patient is having the diabetes mellitus, you are going to treat this one. If the patient is having the hypertension, you are going to treat this one. Atherosclerosis, you have to treat this patient. All the systems should be treated as soon as possible. Next, you also have the potassium mimickers. If the renal stages is already crossed, you cannot get the proper phosphate metabolism in the body, then you have to give the mimetic drugs such as selvamir for the phosphorus. And for the potassium, you have the patiromir. And also some of the calcium mimetic drugs, those are can be given. And for the vitamin deficiency, you have to give the calcitriol. Parathyroid, if the patient is having the renal osteodystrophy or patient is having the parathyroidism, secondary parathyroidism, you have to treat that also. So underlying treatment plus dialysis is the ultimate treatment for the patients of the CKD, right? This is the thing that you have to remember for the CKD. Next, moving on to the glomerulonephritis. So glomerulonephritis, what we discussed earlier, there will be a filtration barrier. So if the filtration barrier is not working properly, then the glomerulus is going to be inflamed. So there is two types of the conditions. One is the nephrotic and other one will be the nephritic. Okay, nephrotic will be mostly seen with the conditions such as, before we see the condition, we'll see the symptoms. So nephrotic patients will be having the proteinuria 2 times the normal, and edema because loss of the protein, which will be causing the hydrostatic pressures disturbances. Next, lipiduria. And also the protein is already lost, which will called as a albuminemia in the blood. These are the symptoms that is present in the patients of the nephrotic. Next, nephritic. These patients will be having the hematuria and hypertension. Edema is also seen in these patients. And proteinuria is just not as much as the patients with this nephrotic, but one time only. And C3 or decreased albumin ratio will be seen in the blood. So those are the symptoms between the nephrotic and the nephritic. What about the causes? The most common will be the minimal change disease. Minimal change disease among the children. Okay. Next, focal segmental glomerulonephritis seen in the adult patients and membranous glomerulonephritis seen in the old age people. Next here, the most common will be IgA seen in the adults and post-streptococcal glomerulonephritis seen in the children and rapid progressive glomerulonephritis to end-stage renal disease seen in the adults. Right? These are the some of the examples for the nephrotic and the nephritic conditions. Next here. So we'll see one by one only most important points that we are going to cover here today. So first one, minimal change disease. First one will be minimal change disease, most commonly seen in the children patients of the nephrotic conditions. So what happened when you see under the electronic microscopy, you are going to see loss of podocytes. Loss of podocytes. Here you can see this diffuse loss of the podocytes that you are going to observe in the electron microscopy. Okay. Next, treatment will be steroids. So very good responsive to the steroids and reversible condition only. Next one. Second one is the membranous glomerulonephritis. Membranous glomerulonephritis. These patients will be most commonly in the old age associated with the other conditions. For example, hepatitis B or C and HIV conditions. Okay. Next, third one. Third one will be membranoproliferative glomerulonephritis. This is seen with the adults. This is seen in the adults who is associated with the hepatitis B and hepatitis C. Okay. Hepatitis B, C, adults, then it is membranous proliferative glomerulonephritis. Old age with the hepatitis B, then it is only membranous nephritis. And whatever the appearance on the histology, you are going to see the tram track appearance. Okay. Tram track appearance is seen in these patients. Next one. Here for focal segmental glomerulonephritis. In the focal segmental glomerulonephritis seen in the adult patients. Okay, adults, autoimmune activity will be seen here. So eitherly the most common cause is idiopathic. Okay, it is idiopathic. And if it is infectious, HIV is the most common cause for this patient. There is a classification that you have to know about this one, Colombian classification. Colombian classification we are going to use. So there will be once this focal segmental. So only particular point of the focally and segment will be involved. Not entire of the diffuse damage will be not seen in this patient. Only particular segments will be defected in this patient. That is not what known as a glomerular segmental glomerulonephritis. Okay. Focal segmental glomerulonephritis. And if it is progressive, what happens? The glomeruli is going to lead to scarring and further sclerosis. Okay. Again, the treatments, it is going to goodly respond to the steroids. Next, here you can see this is diabetic nephropathy. Diabetic nephropathy, most common cause for the CKD patients. What happened? Earliest features of these patients will be basement membrane thickening. Basement membrane thickening will be seen in this patient. Then progressively it is going to cause the Kimmelston-Wilson nodules will be seen. Right? In this picture here you can see. These nodules will be seen in the patients of the diabetic nephropathy as a feature. Next, another one, here comes the nephrotic conditions. Nephrotic conditions, first we have the post-streptococcal glomerulonephritis and second one is the IgA nephropathy or also known as a Burger disease. Okay. First, see, post-streptococcal glomerulonephritis seen in the children, those who have the history of less than 2 weeks of history of the acute pharyngitis or pyogenes related, patient is having the skin condition. Either or there will be a history will be presented. So if you test this also, anti-ASO titers will be positive for this patient. Right? Next, what happening here post-streptococcal glomerulonephritis? There will be a hyaluronic acid. There will be hyaluronic acid antibodies that will be presented. So this will attack the glomeruli, which will be causing here. So the C3 levels, complement levels will be decreased in this patient and hematuria is seen. Classically known as a cola color oil. Sorry, urine. Cola color urine will be seen. So on the scanning, so there will be granularity, granular or also known as a starry sky appearance will be seen on the immunofluorescence, and on this one subepithelial deposits will be seen. Subepithelial deposits will be seen in this patient. Next, IgA or the burger. This is the most common overall, most common in adults. Okay, but this is associated with the less than 1 week history of the infection. Not just strep infections, but all the infections. Okay, it can be viral, bacterial, and other conditions also. Okay, this is less than 1 week only. And C3 levels will be normal here. And you are going to see the only linear pattern is seen here. Okay, linear pattern is seen. This is what IG or the burger condition. Okay, next one. Some of the one of the thing that you have to learn here is the Alport syndrome. What is this Alport syndrome? It is due to defect of genetic condition. Type 4 collagen that is present in the basement membrane is going to be affected here. So this patient is having the triad Alport syndrome. Kidney will involve, along with that sensory neural hearing loss, and also eyes is involved. A for Alport syndrome, A for anterior lenticonus. Anterior lenticonus. And on the histology, on the histopathology, you are going to see the basket weave appearance. Okay, basket weave appearance you are going to see. These are the important points that you have to remember. Next, good pasture syndrome. Good pasture syndrome. The good pasture syndrome will be associated with the renal, and also it will be involving the lungs. Okay, so you are going to see the hematuria in this patient only, and at the same time you are going to see the hemoptysis. Hemoptysis. So this both will be seen, and this will be type 4 collagen defect along with the type 2 hypersensitivity reaction, because antibodies are affecting the both renal and the lungs. Right, these are the important points that you have to take note of the renal conditions. Okay, so those who are new to this channel, please do subscribe and share with your friends, and we will meet up in the part 2. So part 2 will be including neuro, endocrine, GIT, along with the hepatic system, and also we are going to include the hematology. So get ready for the, stay tuned and get ready for the part 2 in our channel. Those who are new, please do subscribe and share with your friend. Thank you, and until then, happy preparation, guys.